a cost-effective analysis to be presented by Dr. Moore from Vanderbilt.
Okay, thank you. I have no financial disclosures. Dr. Zoll, Dr. Sipperstein, members and guests of SAGES, thank you for this opportunity to present our work. The rate-limiting step in organ transplantation is a lack of an abundant donor organ supply. Live donor kidney transplantation offers an essential way to close the gap between recipients and donors. Live donor kidneys also provide better long-term graft survival than cadaveric kidneys. There are three common approaches to donor nephrectomy. The traditional open donor approach, which employs a standard flank incision, the purely laparoscopic donor approach, and then the hand-assisted laparoscopic donor nephrectomy, which employs the placement of an anterior abdominal hand port at some point. With the advent of minimally invasive techniques, there's been a significant increase in the number of potential live donors. And now greater than 80% of transplant centers offer lap donor nephrectomy or hand-assisted lap donor nephrectomy. Therefore, the aims of this study were to develop a decision analysis model to simulate outcomes of donors undergoing the three different nephrectomy techniques, and then to explore the determinants of cost and effectiveness in these techniques. To do this, we developed a decision analytic model to simulate the patient outcomes after the three procedures. Outcomes were simulated from both the institutional or payer perspective and the societal or patient perspective. Plausible ranges for all parameters were based on systematic literature review. Our costs were derived from published studies of institutional costs, Medicare costs, and Bureau of Labor and Statistics. Our direct costs included the cost of the procedures and the hospitalization, and indirect costs included the cost of lost productivity and wages. Our estimates of efficacy were based on pooled results of published studies. This is a slide depicting the decision analysis model. And what you see is the live donor enters the model at the left and then proceeds through one of three procedures. They either proceed successfully through the procedure or they're converted to an open donor nephrectomy. Then they're subjected to a series of complications or uneventful recovery. This table lists the probabilities and ranges with which the model was populated. As you see, the conversion rate for hand-assisted lap donor nephrectomy was about 2%, and that for lap donor nephrectomy conversion to open was about 4%. This table lists the cost and effectiveness with which the model was populated. Again, the direct cost of the laparoscopic procedures was about $10,000, while the open was about $8,000. And the utility of perioperative complications was 0.67, while an uneventful recovery yielded 0.82. And in the analysis here, we looked at the institutional or payer perspective. And you see that open donor nephrectomy is less costly but provides less utility. And take into account, in this perspective, we're not looking at the loss in productivity or wages of the donor. In this model of societal or patient perspective, hand-assisted lap donor nephrectomy is the most cost-effective strategy. This slide depicts that both graphically at the top and at the bottom in a table. And what you see is hand-assisted lap donor nephrectomy, represented with the pink circle, is the least costly and most effective strategy and clearly dominates the other two. In an effort to ensure the stability and robustness of the model, we undertook sensitivity analysis. In this analysis, we increased the days till return to work after hand-assisted lap donor nephrectomy. And what you see is as you increase the days, you reach a threshold of 58 days, and at that point, open donor nephrectomy becomes the dominant strategy. But the average return to work after laparoscopic procedures was about 30 days. So you have to almost double the return to work period in order to make the open donor nephrectomy procedure the dominant. In this analysis, we looked at the conversion rate of lap donor nephrectomy to open. And as you see, as that rate goes to 0, there's little difference between hand-assisted and pure laparoscopic donor nephrectomy. So in conclusion, hand-assisted lap donor nephrectomy is the most cost-effective donor nephrectomy strategy. However, both hand-assisted lap donor nephrectomy and pure lap donor nephrectomy are extremely safe and cost-effective procedures. The two primary determinants of cost-effectiveness in this model are the rate of open conversion and time to return to work. Again, thank you for this opportunity.